Hi, my name is Ashley Mitchell. I am a registered nurse and student at Colby Sawyer College, and this is my presentation on amniotic fluid embolism. Amniotic fluid embolism is a catastrophic and highly unpredictable reaction to amniotic fluid, fetal cells, hair, or other debris entering into the maternal bloodstream. This response involves activation of pro-inflammatory mediator that is similar to an anaphylactic type reaction. And because of this, it is also referred to as anaphylactoid syndrome of pregnancy. It is an extremely rare condition that affects about 1 in 40,000 births in the United States, but it is highly fatal. It is based on clinical diagnosis only, and there is no testing that can be done, but it does tend to exhibit the signs of a classic triad: hypoxia, hypotension, and coagulopathy that results in cardiovascular collapse. Unfortunately, the exact pathophysiology of amniotic fluid embolism is still not completely understood. Researchers believe that the fetal debris entering the maternal bloodstream may lead to the abnormal humoral and immunologic process, which is similar to systemic inflammatory response syndrome. Amniotic fluid contains vasoactive and procoagulant products, including platelet activating factor, cytokines, bradykinin, thromboxane, leukotriene, arachidonic acid. In addition, maternal plasma endothelin concentrations are increased. These trigger intravascular coagulation, broncho and pulmonary vasoconstriction, which leads to cardiovascular collapse. Inflammatory mediators then likely activate coagulation cascade, resulting in DIC and multi-organ failure. In an attempt to decrease the incidence of misdiagnosis, researchers have established a uniform diagnostic criteria for amniotic fluid embolism. This includes 4 things. 1, sudden onset of cardiopulmonary arrest, or both hypotension and respiratory compromise. 2nd, DIC following these initial symptoms. 3rd, this needs to happen during labor or within 30 minutes of delivery. And 4th, there can be no fever during labor. If an amniotic fluid embolism is suspected, prompt response to symptoms is necessary to improve both maternal and fetal outcomes. The first step is providing high-quality CPR in the event of maternal cardiac collapse. If the patient is in labor, left lateral uterine displacement, or immediate delivery during resuscitation to decrease maternal cardiac load is indicated. Rapid delivery is not always possible, but will allow for potential newborn resuscitation to be initiated. This is recommended to be done within 5 minutes of initiating CPR. Plan for intubation for maternal respiratory support. An activation of massive hemorrhage protocol should be enacted. Careful attention to the amount of fluid being instilled via IV should be recorded, as pulmonary edema can be an effect. And an initiation of a code or a rapid response should be called. That way there is more members of the medical team to help collaborate for this care. And the management for amniotic fluid embolism is primarily supportive. The presence of DIC is one of the hallmarks to distinguishing amniotic fluid embolism from other conditions such as myocardial infarction, anaphylaxis, reaction to anesthesia, or pulmonary thromboembolism. The use of the DIC scoring system is recommended in identifying significant DIC, and coagulopathy needs to be detected prior to the loss of sufficient amount of blood in order to account for amniotic fluid embolism diagnosis. DIC may result in massive hemorrhaging, which could be seen from vagina, from cesarean incision, and even urethra or IV sites. It's important to remember that amniotic fluid embolism cannot be predicted, and it can happen to anyone. Some of the potential risk factors that have been identified are placenta previa, advanced maternal age, multiple gestation, polyhydramnios, any induction or augmentation of labor, artificial rupture of membranes, intrauterine rupture, preeclampsia, C-section delivery, or an operative vaginal delivery. But again, it can happen to any laboring patient. The onset of amniotic fluid embolism can be sudden and immediate. Cardiorespiratory arrest can happen within minutes. It's the early recognition and response that is imperative to patient survival. Some symptoms can vary from moderate to severe at the start of amniotic fluid embolism. These may include confusion, anxiety. Some patients report a sense of impending doom. Next could be pulmonary edema, shortness of breath, oxygen desaturation, hypotension, and even cardiac arrest at the same time as those respiratory symptoms. The classic sign for amniotic fluid embolism is a simultaneous hemodynamic collapse and respiratory compromise. The uterus is the first organ that loses its perfusion of oxygen, and when looking at the fetal heart rate tracing, we will see prolonged deceleration in the fetus. Our goals here are to maintain maternal oxygenation, initiate that high quality CPR, plan for delivery within that 5 minutes if there is maternal cardiac arrest, and then start early intubation. Our response to amniotic fluid embolism needs to be immediate and aggressive with our supportive measures. We need to ensure that we have a large bore IV catheter started, and if we do, can also consider using a second line. Planning for a central line because we're going to be anticipating hemorrhage and intubation. We're planning for delivery within that 5 minutes, that immediate delivery. Hemodynamic monitoring and support will be needed, so vasopressors and IV fluids. We're going to plan for continuous ECG monitoring, activation of the massive hemorrhage protocol, our rapid response and codes. And really the best way to prepare for an amniotic fluid situation is to practice with simulation of any OB emergency. It is important to remember that amniotic fluid embolism can often be misdiagnosed in the setting of maternal death. Remembering the set of 4 inclusions for our diagnostic criteria is very important. That sudden onset of cardiorespiratory arrest, or both hypotension and respiratory compromise happening at the same time, the DIC, and the fact that it's occurring within labor or within 30 minutes after delivery, and no incidence of maternal fever. The most common conditions that can mimic an amniotic fluid embolism are hypovolemic shock, reaction to a medication like anesthesia for an epidural or spinal, pulmonary thromboembolism, septic shock, and anaphylactic shock. Because the incidence of amniotic fluid cannot be predicted, it is important to support the significant others and support person involved during the process of resuscitation and continued supportive care, involving all members of the multidisciplinary team, planning for a lengthy recovery process and realizing that there is a very high mortality rate here. For those that are surviving, knowing that post-traumatic stress disorder, there's a high likelihood for that to develop, and there is no known future risk for future pregnancies. The Amniotic Fluid Embolism Foundation is a great resource with their mission to research, promote education, elevate awareness, and provide emotional support for those impacted by this fatal disorder. Thank you for your time. Here are the references to this presentation on amniotic fluid embolism.